Thanks, Nat. Well, let's talk about the pain management and the wound care in neurosurgery. First, about pain management, we all know that neurosurgery can be very painful, and the point is that the patient knows that, and that's what really frights us too. It's an emotional experience, and it starts with the thoughts of the needle stick. So you should reassure that a preoperative consultation is performed very close to your patient. Explain everything. If it's needed, you should draw what you are going to do, as Kendall just show some pictures. Let the patients have all the experience prior the surgery. And more important than that, establish a very good relationship with your patient. That will help not only him to during the surgery and after the surgery, but will really helps you to deal with any complications that you might have during the postoperative period. So as I mentioned before, a nail surgery is an emotional experience. Always remember to talk during the procedure. Make sure that you have a calm and relaxed atmosphere in your consultation room and your surgery room. Remember that children and frightened adults should be you should avoid to show needles and instrument, in special for these two. And starting for nail anesthesia, we just saw from Julia, it's a painful procedure. You only have some considerations that I will remind you. Mostly she already showed very gently and majestic, but let's reinforce that. Regarding the anesthetic products, we have a lot of them. The most useful one is lidocaine and bupi and ropi. I do prefer ropi because it has a quick onset and less cardiotoxic when compared to bupi. But what really helps to us in our daily practice in nail surgery is that we must remember that when we are dealing with these long-standing anesthetic products, we must remember that they allow us to have 8 to 12 hours duration of analgesia, which really helps the patient to have a very comfortable postoperative pain relief. And more important than that is that you do not trigger the pain. And do not trigger the pain. It's very important because you are not only avoiding the patient to feel pain during that 6, 8, or 12 hours after the surgery. But once you do not trigger, all the postoperative period will be with less pain. Dr. Brian Morrison kindly gave me this data that she's about to publish. It's the use of liposomal bupivacaine. I'm not going into details. It's a very unique study. You should go for that, and PubMed soon is under review. But he presented that on the last Council for Nail Disorders meeting, and it's very good and seems to have a very good profile for nail surgery. And of course, we must remember to avoid the pain in the patients. And for that, for reducing that pain from the needle prick, we can use ice pads, topical cryogen sprays, or even cold air. They can be applied for 3 to 5 minutes prior the needle prick, and works very well for children and adults. You can also use massage, works very well for adults, but not for children. Usually they get a little bit frightened. And vibration that works better for children and should be applied 5 minutes before the needle prick. We also have the topical lidocaine that can be used together or not with lidocaine under occlusion for 30 to 60 minutes prior the surgery. It really relieves the pain caused by the needle insertion, which is not that bad. The point is that it not release the pain from the swelling and the deposition of the local anesthetic, which causes that burning sensation. And for that, you can use the anesthetic product with a body temperature. Really helps to try to decrease the pain from the injection. You can mix lidocaine with bicarbonate in a proportion of 1 to 9. But if you go further than that, you can have flocculation and you may impair the flow of this anesthetic solution. And you must remember that a shorter anesthetic duration is expected when you have bicarbonate in the solution. Thin needles are very useful to decrease this burning sensation. We usually use 30G, especially for finger and children, but you can use 27G for the toes. It causes less pain, not only for the picture, but also limits the anesthetic flow, thus performing a very slowly progressive swelling of the soft tissue. And as Julia just mentioned, just keep talking. Talk about your hobbies, put some music, talk anesthesia, change the focus of the patients, make the patients pay attention on what you are saying and not what you are doing. Inform the patient about the needle stick. It really helps you and prevent the patient to have reflex jerks and cause some accident. Regarding the types of anesthesia, we can have very techniques that are described, but a distal block or a ring block or a digital proximal block, wing block, doesn't matter. These two types, usually they are related with less pain when compared to a eponychial block or a transtecal block. And when we are thinking about distal or proximal, as Julia just mentioned, what I think is that we must have in mind that if you go proximally, you must remember that the nervous branches are a little bit thicker, so the chance of having some pain after 6 months or 1 year during the procedure is a little bit higher when compared to the distal block. That's why I usually go for distal block or wing block infiltration of the periungual tissue. So I try, if you are thinking about avoiding pain in the patient, you should consider distal instead of proximal block. And of course, regarding of each type of nail procedure that you are going through, you saw a lot of them now today, this afternoon, you should know to expect how painful is this procedure and know how to deal with that. For instance, we have a lot of painkillers described in the literature, but if you're going for simple procedures such as some biopsy or even nail matrix phenolization, usually simple analgesia is enough. Paracetamol or metamizole is very useful. But if you are going further, like chronic paronychia or some elliptical nail bed or nail matrix excision, you should consider the association of anti-inflammatories such as meloxicam or ibuprofen. And if you go for bone removal of the nail unit, you might consider the use of tramadol or even morphine for some cases. And we have this publication where we try to use something to relieve the pain for the patients after the surgery. We took some patients that were submitted for procedures that are considered very painful or during the postoperative period, and we inject a solution, an anti-pain solution, which is consisted by a bupi or ropivacaine 1-to-1 with triamcinolone 5 milligrams per milliliter, and what we got with this is that it really helps the patients to decrease the pain that are expected regarding these painful procedures. So, and this happens not only because we are using a long-standing anesthetic product such as ropivacaine, but you decrease the swelling with the use of the triamcinolone, so it really helps. So these are some general guidelines for the postoperative period. Always remember to make sure that the patient keeps an elevated limb. It avoids the swelling of the tissue and, of course, decrease the pain. Avoid too tight dressing. Move the digit as soon as possible in order to decrease the chance of a complex regional pain syndrome. Wash the wound. It's very important not only to to avoid the infection, but stimulate circulation. This is very important to have in mind. And remember that depending of the post-operative period that you are dealing to, the procedure, remember that pain may be an indication of infection, so always having that in mind. And talking about dressing and wound, I will give you some very quick considerations. As I mentioned before, just a cotton and some gauze is enough. You can do whatever you want. Of course, that if you have, we have a plenty of things that in the stores that you can buy and use and be much more comfortable for the patient, but only with this you can do whatever you want. And 2 points that I'm going to consider: the nail plate removal, and if you are using a direct suture or a second intention healing. So as mentioned before, every time that you remove the nail plate, the nerves branches are exposed, and that is very painful for the patients. So every time that you can, just put it back, the nail plate. It really helps the patient, gives a pain relief during the postoperative period and a sensation of protection for the patient. You can do it if you have a total nail plate avulsion or even a partial nail avulsion. Remember that if you don't have the nail plate, that's okay, but just reassure that your patient knows that more pain might be expected. And to avoid that, what you can do is to keep the dressing for at least 2 or 4 days. That's the period where usually the pain is more intense. If you do not have, if you can not only use cotton directly to the wound, but you can do an hemostatic one, or as mentioned before, a non-adhesive gauze would be very welcome for the patient, as I already showed you. And regarding if you are doing a direct suture or you are expecting for a second intention healing, for direct suture, it's very easy. You just remove the dressing in the first 24 hours or up to 2 days, it's okay. You make sure that you make the elevated limb, because the swelling will tighten the suture and might be related with more pain. Remember, just wash it, remove the rest of residual blood that you can find, and move the digit as early as you can. And regarding the second intention healing, we have, usually it's a more timing consuming for you and for the patient. The dressings usually you can keep up to 4 days to avoid bleeding. Usually I do that for a super U technique or the total removal of the nail unit. For the hemostatic purpose, you can use a run-locked suture. You can complement hemostatic one and cotton, and then the gauze. And if you can put some ointment, some Vaseline is enough. And of course, if you are dealing with a nail matrix phenolization, usually the size of the wound is smaller. So the dressing for 1 day is enough. You do not have to prevent too much bleeding for that. But remember, phenol causes secretion, some wash, and you can do the use of topical antibiotic in solution, because with this secretion works better during the first to the second weeks of the postoperative period. And after that, if it's needed, you can complement it with the use of some petrolatum or some antibiotics in ointment. And of course, when you are dealing with second intention healing, you can face some granulation tissue that can come. You can use silver nitrate, usually around 10% is enough, or you can just use a curettage of the lesion, and that's worked perfect. And of course, sometimes you do not do nothing, and this is a submatricial cyst where we removed the cyst. As you can see, this is the final defect, and nothing was done. No suture, no gel foam, just wash it, just leave it, and that's the result. So sometimes second intention healing might be a very good option for us. And to finish the presentation, as a take-home message, always remember to have and to establish a very good relationship with your patient, prevent the pain from being triggered. That's one of the most important parts when you are dealing with pain. Know the pain expected from each procedure and be prepared and prepare the patients for that. Remember that the Ropi and Bupivacaine are very useful tools for us, and even if it's associated with triacinolone, seems to have a very good profile. And remember about all the general guidelines that I just saw for all this post-operative period. Thank you very much.
Beautiful.